I had wanted to share something, work in progress. I'm simply promising that those of the young people who are working and who presented yesterday, when we have time, I would love to share it with them, but not now. We've been talking about caste, class, gender, and other inequalities, and we've been talking about how it affects health. And we by now come to believe that evidence base is very important. And over the last 10 years, it has been grilled into us that we were not evidence based, and we now have to become evidence based. I'm here to question that. I'm here to say what my friend Gopal presented is evidence, and there is no girth of evidence, and there are certain areas of evidences that medical disciplines are forgetting, and I want to today talk about historical evidences. Equity, we've been talking about, has been defined by the WHO. Whitehead defined it as a matter of justice, a matter of fairness, and something wherein you provide access to services equally for equal needs. You provide good quality for the same ailments equally amongst all, and you ensure that people utilize services equally. Now, I want to take up utilization and quality, not because I'm going to go into any detail, but simply to say that utilization and quality, as you saw from Professor Gopal Guru's talk, does not come from your skills and professional knowledge alone. It comes from the values that you carry within. So it is the provider which is primarily responsible for both these. And it is the staying power and the perceptions of you, of the underprivileged, who decide these two things. So they are very deeply rooted in the structures of society, just as access is. Services are a social phenomena. They come into being because of historical, political, and socioeconomic trajectories. And this country started very well in the 40s by dreaming to provide basic services to all without any economic demands on you. Over time, we have moved, and we have, from basic health care, we went into, in the 70s, primary health care. That was a very exciting period of mid-70s when the concept of ALMATA, comprehensive primary health care, and I'm not going to go into definitions because I'm sure you all know what primary health care was. And then over time, just like from in the 60s, they talked about equality. And then over time, by 80s, the conversation turned to equity. And people started saying, no, you can't talk of equality, it's very difficult. And I'm not just talking out of my hat, I'm quoting some very important demographers who came up to me in one such seminar, and he said, I think we overdid. We should have only talked of equity and not equality to begin with. And that's how you see a shift. Why? It's not simple. It is because by 70s, the powers to be were too strong and the structures were reasserting themselves. And we did not want to question the structures, but we said, within this structure, whatever fairness I can achieve, I will achieve. And that's how the concept of primary healthcare also, though India became a signatory, it was distorted. It was never really implemented. And what to say of the health sector reforms and what happened later? We have now been given a concept called universal health care, converted to universal health access. Many of us did not in the beginning see the game, and we thought that yes, under the banner of universality we can fight for the same things. But no, it wasn't that simple. It wasn't that simple because universal health care was very different from primary health care. It wasn't promising provisioning. It was only promising access. It was therefore talking of privatization. And it wasn't privatization in the sense that I will handhold the primary providers and I'll work with them, but the government was very clear about corporatization of medicine, expanding the markets and making more and more people go below the poverty line because of the rising expenditures. Thirdly, the entire emphasis was shifting to financing. And we were talking about excessive financial burdens on people. We were talking about catastrophic expenditures. We were not talking about health. So the whole debate was converting to this. They used the term universality, but they began with targeting. And 12th plan is very clear about that. They want to do it on target populations. There is no time plan for universalization. And it was purely clinical. The comprehensive agenda of the primary healthcare was completely lost. So the basic amenities which are primary to health. And this is pretty clear because if you go into the history of UHC, you will find that UHC in the West in the 30s and 40s of the 20th century came up because after the Industrial Revolution, after a lot of people getting securities of welfare, of jobs, the debate was how to universalize. And that's when the states came in, the NHS became an inspiration for the rest of the world, and then different combinations of private and public came up. Now, intelligently, they borrowed that model, they brought it here, they talked of universalization, and they conveniently took out the basics. And that is where I don't hold anyone responsible. It's our own state which has accepted this model, and we have pushed UHC. Now, did the distortion begin in the 90s itself? No. And that's what I want to remind you. I would like to take you back to 1937. In 1937 in Bandung, there was a conference, and the Bandung conference is known in history for its progressive proposal to bring integrated health to the colonies. And what was that? There were two very interesting people, Selskar Gunn and John Grant. These are people who worked in China and India, and they worked with integrated health projects, and they said that you cannot talk of health in countries with such large deprived populations without talking of rural development, without talking of food supplies, without talking of sanitation, education, and what have you. And the discussions in that conference, if you read them, are absolutely amazing, illuminating. And the most interesting thing is that both these people were a part of the Rockefeller Foundation. And even more interesting is the fact that the head of the Rockefeller Foundation, Paul Russell, completely outvoted them, said this won't do. His agenda was simple. He wanted technocentric approaches. He wanted that we don't meddle too much with these societies. He wanted that a small group of experts should be able to monitor and take them where they wanted them, and where they wanted them was to influence very largely the policies and the programs of these countries. And you know exactly this is what happened in post-independent period. We were given all these vertical programs, and in the beginning we thought that we will be able to manage them, but when our own structures started reasserting, we went the way we went. And in the meantime, when in the 70s, third world countries came together, put pressure for PHC, and WHO accepted it, WHO was made to pay for it. And I say this, it was made to pay for it because if you go back in the history of WHO, it was in 1981 that the World Health Assembly freezed WHO's funds. And in 1986, if I'm not mistaken, a little later, it was the World Bank that refused to give its share of funding to the WHO. It reduced it to 20% and forced WHO to start depending upon external resources. And who are those external resources? Just like we had Ford Foundation, Rockefeller Foundation, USAID in the 40s and 50s, you have new philanthro-capitalists today. The Bill and Melinda Gates Foundation are so generous. They go to our villages, they dance with the villages. They fund their international US technology industries to create vaccines for us. So we experiment on our children. And they tell us that technology is the way out. And what is happening today under the banner of UHC is transforming medicine from service for creating health of populations to a commodity which can be sold in the market. You all know the process of privatization. You know, when in 1993 we did the World Development Report, a seminar, friends from Sri Lanka said, why are you people so worried about it? We are doing pretty well. And you go to Sri Lanka today and you see what has happened in Sri Lanka. So this is an agenda. I wish I had time when I could go on talking, but there are just two things. I want to mention two other very concerned groups. One is the Lancet Commission of 1913. I would like you people to read the report of that commission. That commission is telling us that they are for international funds to converge, to build capacities and bring health to the world in the other half. They are telling us, they are setting the agenda as to what priorities there are for the third world. I mean, third world is a huge group of countries with different social contexts, with different politics, different histories. And yesterday, in this one country, we were seeing how many differences in the context there are. Kerala is very different from North, North is very different from Northeast. And despite that, they have given us what they call RMNCH, which is reproductive health, maternal child health, and selected communicable diseases and injuries, and that's the agenda globally. And of course, they are talking about investing in technologies, and that's the way out. Basic services, welfare services are out. Similarly, WHO has been inspired to go in the same direction because they now believe that that is the way out, and therefore they have given us a research agenda. And what is that research agenda? That research agenda again is that we have to do clinical trials for drugs. We have to do clinical trials for vaccines. We have to develop our diagnostics, and we have to use the new methods that are being developed by Commission, Lancet Commission. Earlier there was DALI, and now you have VALI, and which is value added, life years saved, and they are no different. They are same monitorization of indicators, and we are being told that this is the way to go. Now, Lancet Commission is not just a body from the West. It is a group from across the world. And, intellectual groups from different parts are joining it to give a direction. I'm therefore extremely happy that we have here an intellectual group which is ready to challenge and which is ready to ask questions. And I believe that our priorities are in research to very seriously reconsider the kind of research that has been happening in this country, to bring in social science insights, the kind of things that Gopal and many of you have been saying yesterday, and not to look at, I know this is the way you are going, and that's why I'm very happy that we are going to look at caste, class, and gender, and if possible, other things. It's not easy. I've been working with some macro data, and I tell you it's not easy, but we must do it, and we have to do it. So how do we move towards that? Another thing that I think we have to do is, for last 3 plans, we have been saying that there has to be planning intersectorally, and the non-medical inputs must come. And there is always a small page in the plans which is saying this is how intersectorality will be done, which is give it to other departments, make them sit in a committee and let them do it. No, that's not the way to do it. I think you have to take the initiative in your hand. You have to say, what is this basic minimum? How much of water, how much of housing, how much of food, how much of land, how much of transport? You saw Northeast, you go to Himachal and you go to these far off areas, and there are no roads and there is no way a patient can be bought. And yet we want them to come to the hospitals. So what is the basic minimum? I think it is the responsibility of the public health people to define that minimum and to demand that the state provides that minimum. And the third area is in access, we have to move towards systematic systems studies. We have to talk of technology which is amenable for extensive use. We have to develop systems which look at the preventive strengths of curative interventions. We have to develop systems where you can think of using your own resources. And there is a lot of resource in terms of traditional knowledges, in terms of traditional practices, and a different way of looking at systems has to be generated. We have to develop critiques of the new methodologies that are being offered. DALI was critiqued, but very few critics from this group came up. And I think we need to do it in a very big way as to we do not wish to use those methodologies and what are the alternatives that you have. And there is, I know, a lot of research which is going on what the PPPs are doing and what is the impact on health and on systems. And that has to be intensified. And along with that, I believe that if we are serious about regulations, then there is only one way, and that is we must build a public health system which gives a model, which gives an alternative way which by itself becomes regulatory. And it's not just the regulation of the private sector. I believe it is self-regulation. It is regulatory mechanisms within the public systems also. And I would like to end by saying that yesterday, the chair today said to provoke us that, an unequal society is more dynamic. And I want to say, it depends how we define dynamicity. If the dynamicity is in achieving more material goods and consumption for you, then maybe more equitas are more dynamic. But I believe if the dynamicity lies in the relationships you want to develop, in the kind of ethics you want to live by, then to keep a society relatively less consuming society, but a better set of human beings, needs much more dynamism. It needs you to ask, how much must we consume to be happy? Thank you.